and we'll call it SUDEP going forward. It's what everyone should know. This is a sensitive topic. I want to be very careful about how I present this as well. This slide, by the way, has a little green circle in the middle here on a brain, which is really one of the cardiac centers. And the question is, can we turn on and off some of these centers? These include the respiratory centers as well. And on either side is an artwork. It is artwork from an individual who's living with epilepsy. His name is Sean, and I've used this over time. I acquired it about 8 years ago for an art therapy project. I always believe that art is truly neuroimaging. It's probably the first neuroimaging in human history where we can actually see what is inside someone's head, and this is an expression of that neuroimaging itself. So I really enjoy showing probably state-of-the-art imaging by putting one's art out there. Here is my disclosure slide. Although most people with epilepsy live full and productive lives, I want to start by saying that, okay? Too often, however, healthcare providers assure patients that seizures never hurt the brain and are never fatal. Over time, and in some people, certain types of seizures actually can progressively impair cognition and behavior and alter brain structure. In rare cases, seizure can be fatal. Today, I want to talk about what sudden death due to epilepsy really means. In particular, sudden unexpected death due to epilepsy, or SUDEP. So moving forward, I'll use the acronym SUDEP to refer to this term. SUDEP was first debated at the inaugural International Research Workshop on Sudden Death in Epilepsy, held in London way back in 1997. The definition that was adopted was proposed by Dr. Lena Nasheff. According to Dr. Nasheff in 2012, SUDEP should be considered a type of seizure-induced death, along with those causes of death due to status epilepticus, drowning, motor vehicle accidents, trauma, burns, and suicide during a postictal psychosis. However, if someone's death is due to one of these causes, it's not considered SUDEP. SUDEP is definite as a cause of death when clinical criteria are met and autopsy reveals no alternative cause of death, such as stroke, MI or heart attack, or drug intoxication, although there may be evidence of a seizure, such as a bit tongue or pulmonary edema. SUDEP is probable when clinical criteria are met, but there is no autopsy. And it is possible when there is an alternative cause of death or when clinical data are lacking. And of course, it's unlikely when an alternative cause of death is determined. That rules out the possibility of SUDEP, and I already showed you some of the more frequent causes that would not be considered SUDEP. So how common is SUDEP? Well, SUDEP is probably underestimated, first of all, because records and databases are incomplete, and because it often goes unrecognized by coroners, medical examiners, and physicians who are unaware of the disorder or its diagnostic criteria. SUDEP is the #1 cause of epilepsy-related death in people with medication-resistant epilepsy. We'll also use synonyms such as refractory epilepsy, intractable epilepsy. SUDEP accounts for up to just under 10 to 20% of deaths in people with epilepsy. The incidence per 1,000 patients per year varies with the sample population. So I'm going to use this term a lot, and that is in numbers per 1,000 patients per year. There's another strange term, we call this as 1 1,000 patient years. For example, in the US, prevalence of SUDEP is approximately 1 case for every 1,000 people with epilepsy per year. 6 to just over 9 among patients evaluated for or treated with surgery or vagus nerve stimulation for epilepsy. Again, this is a population that probably are more refractory or medication resistant than those individuals who are controlled with their epilepsy. So you get a bit of a biased population when we do this. So this also means the risk of SUDEP is increased 20 to 40-fold compared to the general population. As a rule of thumb, the rate of SUDEP increases with the duration and severity of epilepsy. It's much less common in children than in adults. However, rates of sudden death in children with epilepsy may still be more than 10 times that of children in the general population. Like adults, most children in whom SUDEP is diagnosed die in bed and have a history of generalized tonic-clonic seizures, also known as grand mal seizures. Sudden unexpected death contributes to the increased mortality among children with disorders associated with both treatment-resistant epilepsy, that is intractable or medically refractory epilepsy, and developmental delay, such as autism, Dravet syndrome, tuberous sclerosis, and other genetic disorders such as chromosome 15q11. When compared with sudden infant death syndrome, if you've ever heard of SIDS, 1 in 2,000 infants in the Western world die from SIDS in the first year of life. So this means the risk of SUDEP in children is approximately comparable. SUDEP in children accounts for 30 to 50% of the deaths in severe early onset epilepsies. So again, the worse the epilepsy, the higher the probability of SUDEP. This means it can affect between 1 in 100 to 1 in 500 to 1 in 1,000 epilepsy, people living with epilepsy per year. And so we have to understand, again, the population or that group of patients and their degree of severity of seizure disorder itself. The magnitude of the problem of SUDEP is unrecognized in the medical and lay communities. In a population-based group of children and with epilepsy who were followed for 40 years, sudden unexpected death occurred in just about 10% of patients and accounted for almost 40% of all deaths. Among high-risk patients with major neurologic disorders such as intellectual challenges or cerebral palsy or treatment-resistant epilepsy, rates of sudden unexpected death can exceed 10% per decade. Here's a layout, maybe a better way of looking at this graphically. When you look at one end, you can see children. Okay, so this is the incidence per 1,000 people per year, one way of saying this. And as you go across from left to right, from 0 up, you can see that the more challenging the epilepsy or the more challenging the group of people, the higher the risk of rate for SUDEP. And you can see at the very end, patients who are referred for resective surgery, so that's brain surgery, or actually receiving surgery, depending on the group you're looking at. Among 15 cases of SUDEP in one series witnessed in the community, the death was preceded by a tonic-clonic seizure, so that's a grand mal seizure, in 12 of those 15 people, and was postictal in 2. This is an interesting report here. One person shouted, "I'm going to have a seizure," before collapsing. which suggests that not everybody will experience that last seizure in their sleep. It also suggests that there's something happening, at least in the brain, that's switching off something that is life requiring. Difficulty breathing was observed in 80% of those people. About 70% of patients were found in a prone position, and that means on their bellies. 18 suggesting that suffocation contributed to their deaths. Half of witnessed cases in children were preceded by a tonic-clonic seizure, whereas the other half were preceded by sudden loss of consciousness. Also know a seizure can cause apnea, or the breathing stops, or an arrhythmia, where there's an abnormal heart rhythm without convulsive activity. So you may not see that grand mal seizure. The one cardiac change most often seen is increased heart rate or tachycardia. In fact, in some seizures, one can see heart rate increase regardless. In fact, I would argue that most seizures will show that. By itself, this means that someone is not at increased risk of SUDEP if their heart rate increases. But the finding supports the theory that another mechanism may be involved. One theory most discussed is that a seizure-induced respiratory mechanism may be involved in SUDEP rather than a cardiac mechanism. Determining the precise mechanism of death is often difficult, even for cases that were recorded during video EEG monitoring. So in most individuals who die of SUDEP, no real-time monitoring of blood pressure is performed, no respiratory function was performed, and the findings on an EKG are often restricted in a hospital setting due to one channel looking at all of the EKG by itself, and it's often riddled with artifact. So a respiratory disorder such as hypoventilation could go unnoticed while a cardiac arrhythmia is occurring, which often is secondary to something else happening in the brain. So we can also think of, in the home setting, a change in seizure meds. That person may have forgotten to take their medicine. Also, autonomic function means that there's something going on internally, and the system in the brain, or the on-off switch, is being triggered by the seizure, and that on-off switch controls heart rate, rhythm, gut motility, breathing. So you're actually hitting this network deep in the brain due to the seizure propagating through those circuits. So what we're looking at is the possibility of what we call a cardiorespiratory shutdown happening in the brain. And there's actually a predisposition to regarding genetics and metabolic demand happening in the brain, and even environmental factors, we say.
All I see is the title.
So,
I don't see the person.
Yeah, let me know if you don't see the slide here. Overall, we say this is multifactorial, so lots of things are happening in the brain.
Okay.
So one thing I want to emphasize is that breathing is a big deal here, or the drive to breathe.
Okay, so that's it.
Respiratory rate. Whoops, I'm not sure if everybody is muted here. The concept of impaired respiration as a cause of death is supported by data from studies in animals, and some evidence from most witnessed and reported instances of SUDEP. Seizure-induced respiratory changes can be lethal and may involve pulmonary dysfunction, really, and suppression of brainstem, respiratory, and arousal centers. So it's really the on-off network in the brain that may be contributing to cause of death. Seizures And the postictal state can affect brainstem respiratory centers overall. So central suppression of breathing centers, also called apneas or hypopneas. So the person stops breathing or their respiratory drive is decreased. So this occurrence complicates most seizures because often people are seizing, not breathing already, and they're not able to coordinate their heart and their breathing centers. In one study, people with epilepsy who died suddenly had longer periods of flattened brain waves on EEG, or what we call post-ictal state, where we see generalized EEG suppression of brain activity. Okay, compared with those people who did not die suddenly, they did not have this post-seizure generalized suppression that we see with our scalp EEG. Okay, so again, I want to emphasize that respiration depends on brainstem activity. So it makes sense that prolonged suppression of brain activity can stop respirations. Now, this is a slide that's not so easily seen, but this is a list of what we call suggestive mechanisms of impaired respiration. So there's a lot here, but it comes down to changing the activity of the respiration centers deep in the brain. And that's, should be clear cut here already, that I keep talking about respiratory function as key and cardiac function as sometimes the primary cause, but often the secondary cause from the respiratory centers itself. And there actually are cardiac centers as well. So when someone stops breathing, we see high carbon dioxide concentrations building up in the blood. That's called hypercapnia. So this can cause what we call an acidosis, because carbon dioxide is very acidic in blood, and that can be associated with cardiac arrhythmias as well, and worsening brain function. The effects of prolonged brainwave suppression, and again, we can record this by EEG, and lack of rhythmical breathing to the point where the person stops breathing, we call apnea, can cause swelling in the lungs, we call pulmonary edema. Suffocation can occur in a prone position. That's one theory, where the person's on their tummy. And then overall impaired arousal of the brain, because the brain is so acidic from all that carbon dioxide building up in the blood. And then we can see further some throat spasming happening, and then worsening acidosis in the blood. So this is a vicious cycle. And then that combines with this, what we call cascade of cardiac factors, that cause many cases or people to not be able to wake from this. So this is one long explanation of causes that contributes to SUDEP. Okay. With all that said, I don't want you to ignore the possibility that cardiac factors can still be a culprit here. Okay. So seizure-induced arrhythmias have been shown to occur in people and animals, and lots of studies in the lab. Here's one case series where we've seen, where we saw sudden unexpected death in a group of patients. And in that group of 13 case studies, only one incident was clearly due to a cardiac event. So that's interesting for this one case series. So low blood oxygen, as I just talked about, which is the opposite of high CO2 content. So not only does CO2 increase, causing acidosis, but you're not breathing, right? So you have low O2 in your blood. And that could lower the threshold or make one more prone to heart arrhythmias during the seizure, especially in people with what we call abnormal channels on their heart cells and their brain cells. And these channels that allow sodium and potassium and other salt ions to pass are called mutated channels, and we call this a group, and as a group, the channelopathies. So these people with abnormal conduction channels in their heart cells, muscle cells in general, and brain cells often have some things in common. So, and we've shown this in animal studies, and we've shown this in people dating at least back to the 80s and 90s, where we were able to show this clearly, that the heart and the brain may actually share in common some of these abnormal cells. And so again, this is a group called the channelopathies, okay? And we're not looking at any specific center in the brain itself. As I already mentioned, routine EKGs, where the chest leads are placed on the chest, are often of uncertain value. You have to get some good reportings here. So people who have tonic-clonic seizures or episodic loss of consciousness, who have normal or non-specific findings on MRI, that means their brain looks fairly normal as far as the lay of the land, still should undergo or get an EKG completed, because there are some telltale changes on these simple waves from the heart that suggests the patient may have a channelopathy, or there's a problem with their conduction pathways in the heart. And one of these is called long QT syndrome. There are other types of disorders as well that we can talk about here, but this may be associated with sudden fatal arrhythmias coming from the heart itself. Okay, so I'm going to show you very quickly here two individuals. I'm going to maintain privacy here, so I'm not giving the age, who I had seen recently. One here is a young man, very pleasant individual with a recent onset loss of consciousness episode. The patient continued to have several more of these out of the blue on no medication. The first one was while he was watching TV on the couch, so he wasn't standing, so you don't have to worry about blood flow basically being taken away from the brain by gravity. Some people can't maintain that blood flow. He lost consciousness. It lasted for several minutes. His wife luckily saw this, walked into the room, called EMS, so the ambulance came. He remembered some of this experience, but his wife saw him foaming at the mouth and shaking, as in convulsing. So to her, this looked like a seizure. By her story, this sounded like a generalized or grand mal seizure. He also bit his tongue. So that itself is more evidence that this person experienced a first-time seizure. Never before in his life did he have anything like this. Afterwards, he was confused for up to 2 hours. He had several more of these episodes and finally came to the ER. When he came to the ER, he had an EKG done, and I don't expect anyone to read this EKG, and it may be difficult to see on your screen, but it was not normal in this person who was in his mid-20s. Basically, he had conduction abnormalities on both sides of the heart, and here is his EEG, just a snapshot of an image here showing abnormal brain waves in the front leads. So these are basically leads on his forehead, but you can see some abnormal waves throughout the brain. This may be hard to see, just toward the last probably 10% or 20% of this slide, you'll see the abnormal brain waves. All the remainder of the slide, the beginning of the slide, is normal. So it's really just toward the end of the slide. And sorry, this is a more technical report finding here, but we talked about this being what we call either a primary generalized epilepsy. Generalized epilepsies are often easily treated, but again, he's never experienced a seizure in his life. He had an abnormal EKG, and then he had this EEG, very short EEG as well, just 20 minutes worth, that suggested that there was a connection between his heart and his brain out of the blue. So this is where we thought about a channelopathy. So this is where probably there were abnormal channels for sodium or potassium that were shared by both heart muscle and brain muscle. Okay. One thing we have to also understand is So we don't see here on his EKG that his heart stopped. Thankfully, he's still living. He was actually started on seizure medication for this heart rhythm problem, which probably was related, at least in part, to what was coming from the brain. But someone like this, you do worry this happening again. So you want to think about a pacemaker too. And that prevents the heart from completely stopping. And that's called asystole. So, where you don't see that EKG rhythm for a few seconds. And if it occurs during a seizure, you might even argue that that brain center triggered the heart to stop beating for a few seconds, okay? That is actually pretty rare. And, we see it in less than 1% of all people who have a type of uncontrolled seizure disorder. So that you could even argue is 1 in 1,000 people. You do worry about these individuals. That medicine is a good start, but you may need a pacemaker. And they can easily die. They may not wake up from sleep at night. And as you saw in this history, someone could be awake, watching TV, cooking in the kitchen, and have something like this. So again, even though this is uncommon, I want people to understand that a channelopathy can be something that can occur here. And here's just a list of some fancy terms here that describe some of these channelopathies here, okay? So I don't expect anyone to understand this. In fact, some of the experts have trouble understanding these brain waves for this one particular patient. This is someone else, by the way, where we actually see the heart stop. If you look at the bottom of your screen, you'll see the EKG. So you'll see what we call QRS waves. So that's just conduction going through the heart. That's the red line you see at the bottom. And then you see that that spiky QRS wave go away, just stops. And so the heart stops for 6 seconds, and you can see there, and then it starts again. And if you have trouble understanding the brain waves, which, like I said, most will, because it's very deep in the brain, it's hard to see, you can look at this scan, which looks at blood flow change at the onset of the seizure. And the brightest spot is in what we call the autonomic control center. This is the on switch and off switch area for heart rate, for breathing, for gut motility, for urination, for having the sensation of a bowel movement. So that's in this area called the insula. It's very insulated from the surface of the brain. And this change in blood flow can be seen at the onset of a seizure. This technique, by the way, is called SYSCOM. Maybe some people have heard of this. This is where the blood flow at the onset of a seizure is highlighted, and normal blood flow in the rest of the brain is subtracted away. And then that's matched to the person's MRI. Okay. That's SISCOM, SYSCOM. Okay. And anybody who has a 6-second pause or more really depletes their brain cells in that time frame. And this is where you actually can see one mechanism explaining how people can lose consciousness. So another association here is mood disorders, as in depression and anxiety with SUDEP. People living with epilepsy who have been treated for depression within the last year or so have a 40% increased risk of death for those who have uncontrolled seizures as compared with those who have not been treated for depression. Now, with that said, some medicines like this nice old medicine, carbamazepine or Tegretol, which is still used, it came out in 1974, and then extended release versions came out later. It has been associated with sudden death. This is a sodium channel blocker. It can suppress some of this brain function that we saw from the insula going to the heart and other areas in the body. And more recently, there's been some newer data suggesting another medicine called lamotrigine or Lamictal can be associated with increased SUDEP. Now, there are so many people on these medicines, and I want people to be reassured that this is very rare. It depends on that person's genetic makeup and the seizure type they're suffering from, but more so the genetic makeup. So we just are now seeing this association with lamotrigine, and we ought to think about this when these meds are prescribed. But lamotrigine is really the second most common medicine prescribed out there. So, one type of medication that is used to treat depression is called a selective serotonin reuptake inhibitor, or SSRI. And really that makes serotonin as a type of neurochemical or neurotransmitter related to SUDEP. And so this is something we think about when we consider the mechanisms. I talked a little bit about the wiring circuits, but some of the neurochemicals are important pieces to the puzzle of SUDEP. Okay. So the big question here is, how do we prevent SUDEP? I think this is the probably the $1 trillion question here. Now, again, I don't expect everyone to understand all of this in one slide or even be able to read it, but I want to show that the risk factors here for SUDEP we've talked about. One is a grand mal seizure. That's more likely than what we call a dyscognitive seizure or alteration in awareness seizure. Even though you don't absolutely need that grand mal seizure in some people, that is the most associated type of seizure. And also someone who sleeps prone, that means on their belly or tummy. So these two go together, that increase the risk. So uncontrolled grand mal seizures in those people sleeping on their belly, okay? And often that means they're sleeping, for the longest periods of time during the night, so nocturnal seizures, okay? And these people have uncontrolled seizures. So, what does that mean? Well, technically it means someone who's seizing more frequently than once every year and a half. Okay, that's a definition of uncontrolled seizures, but realistically, some people could seize, weekly. Some people might seize every 5 years, but the risk increases for those individuals who seize more often. Therefore, that's included here. And some of those individuals who are very medication resistant also have intellectual challenges. And you can argue, in part, some people who have cerebral palsy, doesn't mean that is the reason. I mean, cerebral palsy doesn't mean you're going to have seizures, but we see that increased risk in this group of people because of those who are suffering from uncontrolled seizures, who experience grand mal seizures, who lie down at night and sleep in a prone position, and lastly, who may not be taking their meds correctly. They may be on low doses at low blood levels, or they miss their dose altogether. So all these come together as risk factors. And so when we look at prevention, you consider education, right? Take your medicine. You want to be able to know that you're sleeping safely in bed, maybe even a camera monitor or a caregiver checking on someone who sleeps on their tummy. It could be a sound monitor, it could be a video camera overnight. You want to make sure that there could be a seizure monitor in some people who really are not sleeping well. So that is as in a mattress monitor or bed monitor to look at motion in the bed. More recently, people are wearing watches. So I think those with what we call accelerometers in the watch to look at motion in the bed. Some of these can be falsely alarmed. So there's a false positive, we say. So you might think that, you're getting this so often that the alarm that is that people are ignoring the alarm. So you have to be realistic here. So some families revert to a pulse oximeter at night. But again, you might hear this so frequently through the night that you tune it out. So we have to be very cautious in how we're looking at this. And then lastly, we talked about, the cardiac arrhythmia that can be a real challenge. So if that person has this high risk of arrhythmias, or they've been captured, there may be the need for a pacemaker or defibrillator. With all this said, in the end, we're still not sure whether or not we're able to curb the expression of the network that leads to SUDEP. Okay, so let me say it another way. We may not be able to prevent SUDEP with what we know already, but education is important. And I'll tell you, it's still worthy, it's worthwhile to think about all these things and implement them to the best of your ability. I still think as we learn more and more, we're able to understand those individuals that we could help, because there was something that we could actually monitor and change. And in someone else, we may not be able to do this. And you just don't know who that individual is. So vigilance, being alert, being educated is so critical to everyone. Again, never underestimate what is possible. Okay. Reductions in SUDEP may be achieved by increasing awareness on the part of the general public as well, the medical community. This is what we're doing today here, improving the prevention and treatment of epilepsy, of breakthrough seizures itself, and then further developing and encouraging the use of devices. There are a lot of entrepreneurs out there looking at newer and improved technologies that are already out there. And these technologies can alert caregivers. Improving our understanding of the mechanisms of SUDEP absolutely helps researchers and the public to understand what we're working with. So adhere to your medication. I think that's the least we can do here. And I'll tell you, providers ought to educate their patients and families. We should not be afraid to talk about this at least once in a visit. And sometimes that has to be reinforced in future visits, because the patient may say to their provider, "You never told me that." And I think, there's so much going on in a visit that, we just want that person to be educated. So with that, there's so much out there on the web now. Like I said in the beginning, this was formalized only in 1997, which is really not that long ago. And in 2010, the Danny Didd Foundation was founded, and that certainly has raised awareness for the risk of SUDEP, even in someone who's not seizing frequently. You just want people to understand this. And then the strategies that can be used, including some technologies, at least those technologies exist, and that person and family can be exposed to them and potentially utilize them. And some of these may require a prescription, like certain smartwatches. Some you can easily buy. Pulse oximeter is at the pharmacy, and video cameras that connect to one's cell phone. It's so important to understand all of this to help. I do want to show some of the organizations out there. One of these is called Partners Against Mortality and Epilepsy. This didn't begin that long ago. This was founded in 2012, so just over a decade ago. So it started as a conference focusing on raising awareness and understanding of all forms of preventable epilepsy-related mortality. And I showed some of these at the very beginning, including suicides, accidents, status, and SUDEP. So it's a collaborative initiative that's housed within the American Epilepsy Society. Their meetings are unique in that they convene healthcare providers, basic and clinical researchers, public health officials, advocates, death investigators, coroners, medical examiners, people living with epilepsy, bereaved families, those who unfortunately have suffered a loss of a family member. It's all around shared agenda here. So it's definitely grown over the years as a strong and diverse community. And so, it really has only recently, actually maybe a year and a half ago, amplified its ongoing educational opportunities. and you know, the ability to understand what's out in the research world and what gaps there are in the field. So I think we're going to see this more and more as we move into the near future. And again, other organizations, there are so many out there. So I think that's something we couldn't have said even just a decade ago. So I'm very excited to see how far we've gone with understanding SUDEP, and there's so much great research going on as well. Also coming up is epilepsy, World Epilepsy Day. And so this is something actually originated by the Epilepsy Association of the Maritimes in Canada, the Anita Kaufman Foundation. So again, it's to promote epilepsy awareness around the world. I'm going to stop there. This is about 45 minutes in. I want to make sure people have time to ask questions. I may, let's see, stop sharing my screen and just turn on my video.